All right, chapter 29, Pain and Comfort. So the International Association for the Study of Pain, it defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described as such. So I want to make the point again that pain is not an inevitable part of aging. So just because you're older doesn't mean you'll have pain. And sometimes I think we think that. Pain is multidimensional. It has sensory, psychosocial, emotional, personal, and spiritual components. And we categorize it as either acute, chronic, or persistent. So these are different types of pain. You've got nociceptive pain, which is actual damage to body tissue. And this is what we think of when we're talking about like a sprained ankle or a broken bone or arthritis. That's the nociceptive pain. Neuropathic pain, this is caused by disease of the peripheral nervous system. So some examples of this are, for example, diabetic neuropathy. This affects the nerve pathways in the body. And so people with diabetic neuropathy get numbness or tingling mostly in the lower extremities. And that is very problematic and very painful for them. So we usually treat that with different types of pain medication. You wouldn't necessarily treat that with the same kind of pain medicine you would treat a broken ankle. But instead we use some medications like Lyrica, gabapentin, and those types of pain medications. Acute pain, you all know what acute pain is, and then chronic pain generally lasts more than 3 to 6 months. The most common type of pain in later life is persistent or chronic pain. And the one thing I want to make sure I stress is the number one side effect from chronic pain is actually depression. People with persistent pain are much more likely to be depressed and to have sleep disorders than people who do not have physical pain. So if you just think about being in pain all the time, you can understand how that would definitely cause depression. For the older adult, more men than women usually report pain. And some barriers to pain management in the older adult, you can look in your chapter. Box 29.5 has some barriers. The impact of persistent pain. This can actually cause like chronic diseases if they're having persistent pain that is not treated. With aging, there's a difference in pain perception and pain tolerance. So there's a slight delay in pain sensation, and there's usually a slower resolution of pain. What's really particularly tricky is trying to determine if there's pain in someone who's cognitively impaired. So people with cognitive impairments are consistently undertreated for pain. Older adults who are cognitively impaired usually receive less pain medication even when they have the same experience as someone with an acutely painful event. And I can share an example of this. When my grandma had Alzheimer's, and she was in a later stage where she really couldn't communicate, and she broke her hip, and she went into the ER, and she actually sat up in a wheelchair for about 2 hours before anyone came and before they took her back and did x-rays. And if that had been someone who was not cognitively impaired, I don't know that, they would have been saying this really hurts and would have been getting more attention. So I always think of that. Providing comfort requires very careful observation of behavior, and paying attention to the caregiver who knows that person. The person most likely to be able to tell if there's a behavior change is the family or the caregiver. So some pain cues that may happen in the cognitively impaired are like facial grimacing, moaning, crying. You may see a change in vital signs, so perhaps a elevated heart rate, or maybe they start breathing faster. Changes in how they behavior or even in diet. So just paying attention to all of these subtle things. Pain management is, we do both pharmacological and non-pharmacological interventions, and we work on those together. The basic approach, you consider what has worked in the past and what has been effective without causing any kind of harm. So you guys are familiar with pain scales, but there are different pain scales that we'll talk about. Usually you do assess pain when you're assessing vital signs. You may encourage the person to keep a pain diary where they will write out like what kind of pain they're having and what happens when they're having this pain. Again, Old Cart can really help you in knowing what questions to ask. And then anytime they have pain, I just want to stress again that you want to screen for depression and anxiety that can exist together. Rating the intensity of pain, we usually use rating scales, and so you may be familiar with this, or you are familiar with this, the numeric rating scale. So on a scale of 0 to 10, with 10 being the worst pain and 0 being no pain, where would you rate your pain? Or there are the Wong Baker, I believe that's what these are called. These are the FACES pain scale, where you can see this person has no pain, they're smiling. This person has severe pain. So that's another way, if they are able to do the numeric scale, you could have them point to the one that looks like them, looks like how they're feeling. Again, with the cognitively impaired, it's recommended that attempts are made to use a standard assessment instrument even when the person has advanced dementia. So trying to use a pain scale. So there is a sheet, and I don't think I have it here, but it's the PACSLAC-II, and it's a behavior assessment tool. And it goes through things like, is the person crying? Are they moaning? Are they putting their eyebrows together? And it goes through all of those behaviors, and you kind of check boxes to help you determine if the person is in pain or not. I do have the link here if you want to take a look at that. Interventions. So we start out with non-pharmacological interventions. Heat and cold therapy can be really effective. Exercise, it can be painful at first, but then it can help over time to decrease pain. A TENS unit, which if you're not familiar with what that is, a TENS unit is something they use quite a bit in a physical therapy office, but it's got a muscle stimulator, and you put that on, you put a patch on the muscle and you turn up a dial, and it actually like contracts the muscle, and it can cause pain relief that way. Acupuncture or massage can be helpful. Relaxation or using guided imagery. Music, using music as a distraction and non-pharmacological measure, and then cognitive behavioral therapy. Principles of pain control. Every older adult deserves pain management. The treatment, you want to base it on their individual goals. And always, pain is whatever the person having it says it is. It's very subjective. We can't look at someone and say, just because they're not crying, they're not having a pain of a 10 out of 10. If they tell you their pain is a 10 out of 10, then that's what it is. And that's what you will record. Also, there should be ongoing evaluation of therapies. So whatever you're doing to treat pain, you need to be evaluating it. There's actually, I know nurses who've gotten in trouble before or been written up because they gave pain medicine and then they didn't document a reassessment of pain, after an hour or 2 hours. And so that is serious, and you can get in trouble for that. And then also you want to prevent or manage any of the side effects from pain. Pharmacological interventions ease the memory of pain. They don't simply relieve it. There is type of pain medicine that's around the clock dosing at appropriate dosages. So that's where the person takes scheduled pain medicine, every day, maybe in the morning and at night and at the same time of day. For breakthrough, so that would be scheduled. But then they have PRN pain medications, which you guys are familiar with. And this is for breakthrough type pain. So if they are, if they took a pain medicine in the morning and then they start having pain at 11 or 12, then you would give a PRN pain medication to get them through until the next time. So current recommendations are to always start with the lowest effective dose and then increase it slowly. So we use the saying start low, go slow, but go. So start with the lowest treatment. If someone has an order for 2 to 10 milligrams of morphine and they tell you they have pain, you don't want to go in and just automatically give them 10 milligrams off the bat. You want to start with the 2 and see if that treats it. And if not, then slowly, incrementally move that up. So we have non-opioid analgesics, and this is like acetaminophen or ibuprofen or Motrin, any of those. So the acetaminophen, it used to be that you could take 4,000 grams per 24 hours, but now it's actually limited to 3. So you do have to be careful because a lot of pain medications have acetaminophen in them, and if that's the case, they can actually be overdosing and not even realize it. That's the same is true with the non-steroidal or the NSAIDs. Those are also commonly put in combination with other pain medications. So probably not as common as Tylenol, but it does still happen. Opioid analgesics, or your scheduled analgesics, are tramadol, morphine, and fentanyl. Tramadol is an oral medication that you would give. Morphine, of course, they have oral and IV morphine, and morphine doesn't have a cap. You can give as much of it as you need to control the patient's pain, but you do need to caution yourself because you need to really watch symptoms. It is a narcotic, and so it does decrease the respiratory drive. So the more morphine you give, then you want to watch that they're not over sedated and they're not having any difficulty breathing. The same with fentanyl. Fentanyl is common in patches, is like skin patches, and that is commonly overdosed and something that you will see. Like for example, Narcan. Narcan is they have a nasal spray now where you can give Narcan to reverse pain medicine, and a lot of the police officers will keep Narcan. A lot of people will, the pharmacies will give out or Narcan, or people a lot of times, a provider, if you're prescribing a narcotic pain medicine, then you go ahead and give them Narcan so that they can have it. They can have it in case of an overdose. And then you've got adjuvant drugs, and these are drugs that are intended for one reason, but then they also kind of help to treat pain. So the ones that I think of the most are like gabapentin, which is a medication that's actually an anti-seizure medication, but we use it to treat neuropathic pain and like neuropathy. So anticonvulsants are another, that's the anticonvulsants. Antidepressants, we do commonly treat, especially chronic pain, with antidepressants, and you can see a big change in that. I had a patient that she was in a lot of pain, and we had tried a lot of different things with her, and we finally tried a certain antidepressant, and it really helped with her pain. Unfortunately, it caused her liver enzymes to go up, and so we had to back off on that, but that can be quite helpful. And then there are some herbal preparations which can be helpful as well. Pain clinics, there are pain clinics that provide really specialized multidisciplinary approaches to pain management. This is especially helpful for people who have refractory pain or who the usual standard approaches to pain hasn't worked for them. So that's kind of the next step, is for them to see a pain management specialist. Interestingly enough, a lot of pain clinics don't prescribe pain medication. So their interventions are geared more towards like injections, or they'll put like neurostimulator devices in. So just because it's a pain clinic doesn't mean that they'll even prescribe pain medication. You always want to evaluate how effective you were in relieving pain. So I talked about that a little bit before, but always go in and don't just ask, but chart what their pain relief is. So an effective pain assessment tool would be all of the above: the pain diary, the FACES scale, the numeric pain scale, and pain is whatever the client says it is.